Well, thank you for that lovely introduction. And thank you for all that came here today. I'm certain it wasn't for the free food. I'm certain it was because you care. And you care because this has impacted you. It's impacted friends and family and coworkers. And that's either because of direct exposures or because as administrators, physicians, psychologists, researchers, it's impacted you in ways that many of us couldn't even begin to describe. And when we're doing this, we have a unique challenge. And that unique challenge is to remember that we have two functions. The first function is obvious, and that is to take care of the individual patient. That person who comes to us is looking for advice, is looking for treatment, and in many ways is looking for closure. And I remember distinctly being at the bedside of a person who was dying from cancer, a firefighter, and his family was around him, and he passed on. And he had many young children, and it was a very emotional event, as you could imagine. And the priest came in and said a few words. It helped a little. And then someone, I can't remember who, said, "You know, your dad was a hero because he died of cancer because he was there helping people on 9/11. There was no scientific evidence at the time that cancer was related to 9/11. There was no multi-million-dollar program paying for his cancer treatment. There was no World Trade Center logo over his bedside. But that family, for a moment, and I hope a moment that lasts forever, but I know for that moment, that family had closure. That family didn't need scientific evidence. They didn't want scientific evidence. For them, Dad was a hero. That was something that we gave to that family. And by now covering cancer, that is something we can offer to every family. Family of survivors, family of responders, family of patients that succumb to their disease, family of patients that don't succumb to their disease. It's more than about research and money. It's about taking care of human beings and their quality of life. That is our challenge. At the same time, we have another challenge, and that is a fiduciary responsibility to the federal government to say there is some science behind this. We hope that there's compassion. We hope, as Dr. Howard did for cancer, that there's compassion, that modest evidence can move us forward, because to not move forward is to miss an opportunity to provide the solace that I just mentioned, something that is invaluable. So we hope that there's compassion, but there still needs to be some science because we have a fiduciary responsibility. Because we need to have what I often call data-driven advocacy. Right? Advocacy without data ultimately winds up being a program without credibility and a program that can't grow. And one of the beautiful things about our program is that it has been based on data-driven advocacy. The clinical centers, the data centers, the researchers have provided clear evidence, all right, for respiratory and mental health problems related to 9/11, and increasingly clear evidence for the same related to cancer. All right. A modest increase in cancer only 8 years after 9/11 is significant. And we're finding that our future studies are going to demonstrate, I think, that level of data-driven advocacy and the confidence that the federal government had in our data is well-founded. And it raises the question about what about something else? Right? What about other issues? Right? And we've been spending a lot of time on that, obviously. What we need is your compassion towards us as researchers, because it takes a lot of time. And I'm supposed to be talking about what it takes to do that today, and we'll learn more in the workshop. But we ask a lot of questions at the annual monitoring exam, and we ask them over and over again, and then we ask more, and people can get frustrated with that. But we're not looking for just one disease. Let us postulate or think for a moment what it would have been if we did what would be a quick annual monitoring questionnaire. On 9/11, the obvious thing to those of us who did care, thank you, Dr. Brahman, was mental health, PTSD, and respiratory, all right? And clearly, as a lung specialist, respiratory is foremost. So if that questionnaire was designed with just that in mind, we would have 150 lung questions and maybe 2 or 3 mental health questions, and that would be it. But we had a broader purpose. We wanted to ask questions about cancer. We wanted to ask questions about autoimmune diseases. We wanted to ask questions about potential toxic diseases like liver diseases, kidney diseases, et cetera, and therefore the questionnaire kept growing. And when you come to answer that questionnaire, that is our beginning basis for picking up data. Right? And then we do tumor matching, and then we do treatment exams, and all of that data has to come together. And it has to come together in a way that is somewhat convincing so that we can move forward. And we are working very hard on that. All right? But to get that data requires comparison studies. It requires that we look at control groups. The tumor registries provide us with the control groups for cancer studies. Looking at other workers with less exposure or no exposure provides us with control groups for many of the diseases, but these are control groups that are difficult to come by. There are always differences between controls and our own groups that make some degree of uncertainty, and that's why we need multiple studies. And that's why the federal government has said, when we presented what I believe to be overwhelming evidence that autoimmune diseases are increased, the federal government said, well, we need to see corroborating studies from the other groups, which actually is one of the strengths of our program. People initially said, well, you don't need to have a general responder group and an FDNY group and a survivor group, or maybe you just have one group and you just ask the same questions to everybody and that'll be perfect because there's more power in numbers. And these are people that don't really understand. There's more power in numbers, but there's also more power in comparisons between different groups that then find the same evidence. That's what happened with cancer, and we're waiting for that to happen in autoimmune, and I feel very confident that it will. And then we'll go on to the next, and the next, and the next. But we're now getting an increasing challenge. And that increasing challenge is not just the comorbidity impact of all of these diseases together, but there's an increasing challenge of 2 comorbidities that we all deal with in our own lives, all right, that challenge each of us as individuals. And that is, unfortunately, aging and obesity. All right? And many of the studies, many of the diseases that we are looking at now, many of the questions that are being asked to us by our own patients, loss of memory, all right, inability to exercise, increasing shortness of breath with activity. Many of these are some of the same things that we see due to aging and obesity. So what I want to do is provide you with confidence that we're looking at this, but what I also want to do at the individual level is empower you, all right? Empower you to make a difference in your own lives, all right? And that is to avoid future toxins, to continue to exercise and lose weight as hard as that might be, and the biggest challenge, but which I know that at least I am capable of, is to never age.